So good evening friends, I hope I am audible. Checking audio. Yeah, I am verifying on another device. Just a second, we are going to start. So good evening friends, I hope I am audible. Okay, everything is fine. We will start the class. This is going to be a fast session. We are going to discuss around 200 questions. I'm not going to discuss any new question. Whichever is asked in the past 3 years of FMGE exam, all the questions we are going to have a fast review. There are high repeats in FMGE exam, so you should be thorough with the repeat questions and the concepts related to those questions. Okay, if you have any doubt, you can always post, and we are going to see one by one. The section 1 we are going to discuss is on the general aspects of surgery, including trauma. So let us start the discussion. A patient presented to emergency after RTA with a multiple rib fractures. So please understand, this is a question on trauma. So in trauma, definitely you are going to get 5 to 6 questions in this exam. So patient coming to you with a trauma, with the multiple rib fractures, he is conscious. Please remember, he is conscious, speaking single words on examination. Respiratory rate was 40 per minute. BP is 90/40. What is the immediate next step? Okay, this is what is an immediate next step? You should know. The immediate next step is usual question. So when you see a trauma patient, you should understand what should be done in a case of trauma in primary survey. Please understand what do you mean by primary survey. You should understand what is primary survey. Primary survey in a trauma patient is A, B, C, D, E. So A for airway, B for breathing, okay, C for circulation, D for disability, and E for exposure. Please remember, it is E for exposure. So exposure is E. So this is A, B, C, D, E in a trauma patient. So in this question, if you see patient is conscious and speaking single words, means his airway is good. So please understand, his airway is good, so no need of intubating the patient. So always, if you understand and answer the question, you are going to definitely crack this exam in a simple way. So airway, immediately intubation of the patient is not needed, because a patient is speaking and is conscious, means he is breathing well. So no need to intubate. Okay, therefore intubation is not needed, and we have no time for X-ray chest at this point of time, because patient is having multiple rib fractures. In a multiple rib fracture patient, there are chances of him having a pneumothorax. So there is a chances of him having a pneumothorax. So therefore, this case is typically having pneumothorax is a more chances of pneumothorax is high here. So we can insert a needle in the second intercostal space is an immediate next step. So in this question, you should think of tension pneumothorax. So this is a case of tension pneumothorax. So why, you can ask, why not you go for urgent IV fluid administration? Please remember, circulation is third one. First one is airway, that is intubation. Second, I am telling you again and again, the same question will come, and the remaining questions I may not be giving you the detailed explanation. Please understand the basics of any trauma patient. Any trauma patient coming to the casualty, you have to see whether his airway is good. How to check for airway? He will speak. If a patient is speaking, sir, I am fine, I am able to speak, means his airway is good. Number 1. B, breathing. If he is not able to breathe properly, means he is having a problem in the chest. So the most important problem you should note here, the clue given is multiple rib fracture is a clue here. Catch point is that we have to treat the tension pneumothorax. Tension pneumothorax is a clinical diagnosis. We cannot wait for an X-ray. X-ray comes under secondary survey, not in primary survey. So in a primary survey, if you suspect there is a pneumothorax, immediately put a needle in the second intercostal space. Then only comes circulation. You can see the BP is very low. Whenever the BP is low, we are going to infuse fluid. Yes, we are going to definitely infuse fluid. That will be the third step, not the immediate next step. Please understand, the question is very clear. What is the immediate second next step? So Bailey says, as of Bailey, where will you insert the needle is second intercostal space in the mid clavicular line. This is a classical line from Bailey. In FMGE exam and all, they won't ask you the ATLS 10th edition guideline and all. They won't ask you ATLS 10th edition update. ATLS 10th edition update says we have to insert it in 5th intercostal space in mid axillary line. Unless they mention this term, ATLS 10th edition term is not mentioned, you go for second intercostal space in the mid clavicular line. Okay, so in the mid clavicular line, we should treat this. So fifth intercostal space, mid axillary line, we have to put a needle. Okay, Herman, flail chest, the first thing is to have an analgesics. To give an analgesic is the first treatment. Okay, so we have to give analgesics for flail chest. So the next question is correct posture of. Are you clear? The first question. So most of the questions are repeat areas only. I'm discussing the question paper from FMGE 2019 to December 2021 in a systematic way. General aspects of surgery, we are starting the discussion. The first question is discussed just now. We have to first put a needle in the second intercostal space because we expect it can be a pneumothorax. Correct posture of inserting a nasogastric tube. So this is a AIMS question asked in the next exam in FMG. Sometimes the AIMS question will be asked in FMG exam. This is one such question. Correct position of inserting the nasogastric tube is sitting with neck flexed. This is the correct position, and this position is known as Fowler's position. Please remember the name of this position is Fowler's position. Sitting with neck flexed is a 100 times asked question in various mock exams. So this question you should never make a mistake. Now the question is, how will you know that tip of the Ryle's tube is in the stomach? So what is the best method to confirm the tip of the tube is in the stomach is by means of aspirate and test for pH. pH should be acidic. That is the best method to test to look for the position in that stomach. So how will you know the position of the Ryle's tube in the stomach is aspirate and test for pH by using a litmus paper. Okay, by using a litmus paper is the answer for that question. So simple question. So please don't make mistake in these type of questions. How to insert a Ryle's tube sitting with neck flexed, and I hope most of you know what is this next rule. Next rule is ideal length of Ryle's tube is calculated by nose. Take a tape from nose to ear, and from ear to Ziphisternum make a measurement. That is the ideal length of Ryle's tube in adults. In children, it is Nemo rule. In children, it is Nemo rule. Nemo means nose, ear, midpoint between umbilicus and Ziphisternum. Okay, midpoint between umbilicus and Ziphisternum is for pediatric cases. So please remember, next rule and Nemo rule are the two rules used for finding out the ideal length of Ryle's tube. So no confusion in that. So please remember, next rule and Nemo rule is related to Ryle's tube. So Ryle's tube is a basic question. Definitely you will get questions from Ryle's tube. No doubt in that. Please remember that. And don't go to exam without reading Glasgow Coma scale. Let me tell you the simple method to remember the Glasgow Coma scale. I think most of you attended the classes. You will be knowing that GCS, Glasgow Coma scale, is based on eye opening, verbal and motor response. These are the three things we use in GCS. Eye opening, verbal and motor response are the three things we use in GCS score. Please remember, eye opening is spontaneously the patient is opening, we give 4 points. On commands, when you call him, he is opening, that is 3 points. On pain stimulus, it is 2 points. Not opening is 1 point. So this is scoring for eye opening. Verbal, you just remember this phrase of mnemonic. The mnemonic is, so the mnemonic is, you have to understand one confused word. One confused word sounds nowhere. That is a mnemonic. Okay. One confused word sounds nowhere is the mnemonic. So one for oriented. When the patient is oriented, give 5 points. Confused, 4 points. Inappropriate word, third, 3 points. Incomprehensible sound, 2 points. No sound, you give 1 point. So verbal response is 1. Confused word sounds nowhere. So oriented, 5 points. Confused, 4 points. Inappropriate words, 3 points. And sounds, 2 points. No sound at all, no response at all is 1 point. Motor is obey, localize with flexion, extension now. That is a mnemonic for motor response. So obeys commands is 6 points. Please remember, if a patient is obeying the commands, we give 6 points. Localizes the pain. Where is the pain? He is telling, I am having pain in the right arm. So that is 5 points. Withdrawal, 4 points. When you touch him, he is withdrawing. Patient lying in flexion deformity known as decorticate rigidity. You would have read in medicine, decorticate position. The patient is lying in a decorticate position. Patient lying in a decerebrate position. Decerebrate position is 2 points. No response is 1 point. So this scoring alone they will ask you. They won't ask you. They won't ask you much questions related to other things. Please remember this thing. Okay. So which image is not clear? I don't know which. So we will be discussing, just you have your doubts in your hand. When all the questions which are asked in your exams are coming up. So definitely you are going to get clarified of all your doubts. So please have it in your mind. Definitely I'm going to clear all your doubts. Okay. So eye opening on pain. What is the score? Pain, 2 points. Confused is 4 points. Okay. And exhibits flexion on painful. Flexion deformity is seen. Flexion deformity is 3 points. So this is E2 V4 M is flexion is 3 points. So the answer here is 7 plus 2, 9 is the answer here. Okay. So E2 V4 M3. So this is a simple method to remember. Remember the mnemonic I am telling you. Obey localites with flexion extension now. Obey localites with flexion extension now is for motor response, and one confused word sounds nowhere is verbal response. So 4, 5, 6 for each. This question is definite question. You are definitely going to get at least one question from GCS. Okay, please remember that. So we are going to discuss, I am telling those who are all new to the class, we are going to discuss around 200 questions of the past 5 papers from 2019, 2020, 21. All the papers of FMGE exam. I am going to give a fast review, and I am going to clarify any doubts you are going to have at the end of each section. The first section we are discussing is on general aspects and trauma. Okay. Most appropriate management of keloid. I hope you know what is keloid. Keloid, I am seeing it's a favorite topic for your examiners. They are regularly asking questions in your exam. Keloid is a scar. Is a scar seen on extensor surfaces. Please remember, hypertrophic scar is another scar which is seen on flexor surfaces. Hypertrophic scar. So you should know what is the difference between hypertrophic scar and keloid. Hypertrophic scar is seen on flexor surfaces, and if this is the previous wound, the hypertrophic scar will be limited only to this wound. Whereas if this is a wound, the keloid will extend into the normal skin also. You would have seen keloids in the chest, somewhere other places also. Keloid is a very commonly asked image based question. Question is coming back again. So keloids are seen on extensor surfaces, and it is a maturation of immature fibroblast. It is caused by immature fibroblast, whereas hypertrophic scar is mature fibroblast. So please remember one important thing, hypertrophic scar can be operated by surgery. We can do surgery. Whereas keloids, if you do surgery, it will recur. So surgery is totally contraindicated, and we have to do only intralesional injection of steroids. Steroid injection is done mostly. So this is a commonly done treatment, intralesional. The inside the keloid we put steroid injection inside. So the intralesional injection. There is a new treatment now from Bailey and Love, that is intramarginal excision followed by radiation. This is a new treatment. Please remember, this is a new treatment B. Old treatment is steroids. But even now we are doing steroids, but for recurrent cases we have to go for intramarginal excision followed by radiation. Vincent Vega, wherever the scar is seen, you can identify whether it is a keloid or hypertrophic scar by seeing the image. In the ear, if you are going to get something, it is keloid only. In the ear, something is happening, is usually a keloid. Okay, the steroid injection is the first line treatment for them. If there is a recurrent keloid, go for intramarginal excision. Means if this is the scar, we exactly excise it close. After excising that, we will give radiotherapy to that area to prevent immature fibroblast formation. That is the concept of question number 4. So question number 5, seat belt injury. So we are going to discuss 200 questions. This is the 5th question. Seat belt injury leads to. So we are wearing a seat belt. So when you are going to have an injury like this in a car accident, What organ is injured most commonly inside the GIT? So the most common organ injured in seat belt injury is mesenteric tear. Please remember, mesenteric tear. What happens if there is a mesenteric tear? That is a question here. This is a, for example, this is the bowel and this is the mesentery. The mesentery will have blood vessels going like this to the bowel. If a mesentery gets a tear like this, the blood vessel to the bowel will be lost and the bowel will go for gut ischemia. So gut ischemia. So the answer is C, gut ischemia. So what is the most common organ injured in seat belt is mesenteric tear causing GIT ischemia. The bowel will go for gangrene. Number 2, most common organ injured in blunt trauma. What is it? Blunt trauma of the abdomen. Blunt trauma, answer is spleen. Most common organ injured in penetrating trauma, answer is liver. Okay. So these 3 questions are very basic questions for FMG level. Please don't get confused in this. So most common organ injured in a seat belt injury is mesenteric tear. Most common organ injured in blunt trauma is spleen. Most common organ injured in penetrating trauma is liver. Okay. So this is very important simple question for FMG exam. Which of the following is not scanned by fast ultrasound? Very interesting question. Fast ultrasound which is not done. Simple question. So please, you have to understand now that new thing what we are doing is E-fast. Okay. Now what we are doing is E-fast. Previously we were doing fast. Now what we are doing is E-fast. What is E-fast? E-fast is 6 regions scanned by the radiologist. Fast is only 4 regions scanned by the radiologist. What is fast? We focus on 4 areas. One is pelvis, right hypochondrium, left hypochondrium and epigastric region. This is for liver, this is for spleen, this is for heart to look for pericardial tamponade and this is for pelvis. So in a fast ultrasound only 4 regions are focused to look for any collection. More than 100 ml of blood in any of these areas is detected. Less than 100 ml fast is not useful. Please remember, less than 100 ml fast is not useful. More than 100 ml we can find out. There is 2 more regions added in extended fast, that is right side chest and left side chest. In that only we can see the pleural cavity. So in a normal fast, pleural cavity cannot be scanned. Okay, pleural cavity cannot be scanned in fast. Okay, please don't forget this point. Very simple question. You have to follow this. So more than 100 ml, we have to more than 100 ml only we can detect. Less than 100 ml, we have no way to detect in E-fast. Okay, so the very important point. Please don't forget this. Next question is on right chest and left chest. We can only find out in E-fast, and in that the pneumothorax, what will be the finding? Can you tell me? In a pneumothorax, what will be the finding in E-fast? In E-fast, what will be the pneumothorax finding? Okay. So pneumothorax finding we get in E-fast is seashore sign or barcode sign, seashore sign or barcode sign or stratosphere sign. So the sign seen in pneumothorax is seashore, barcode or stratosphere. So some books will say seashore is a normal finding, but ATLS manual says all these are findings in pneumothorax. All these are findings in pneumothorax. Very good, Vincent. Very good. Ashwani, very good. We're happy to see 110 students are attending within 10 days before the exam. So definitely this 2 hours is going to be very useful for you, and you are going to crack, with this 2 hours you are going to crack at least 25 surgery questions correctly. I am 100% sure 25 questions you will crack it without reading anything. When you remember what I am telling, you will answer. Okay, please remember this. Prophylactic antibiotics to minimize surgical site infection are given dash. When will you give prophylactic antibiotics? So prophylactic antibiotic is the latest norms as per new protocols. We have to give antibiotic 1 hour before skin incision. This is a direct line. Don't get confused. You remember this alone. There may be so many confusion. So many books may be giving wrong. This is the correct answer. Okay, 1 hour before skin incision. That's what I'm telling you, Sharma. That is what problem is. Some of the radiology books are mentioning seashore sign for normal people also. But ATLS manual, it is mentioning all three are mentioned under pneumothorax only. Okay, it is mentioned in pneumothorax only. So probably radiologist would have discussed you as seashore as normal finding. Seashore, barcode, stratosphere, all are seen in pneumothorax as per ATLS manual. Okay, surgical site infection is prevented by giving antibiotic 60 minutes before skin incision is the correct answer, A. Okay. So 100% I am sure you are going to get at least 1 or 2 instruments for your exam. So in all the instruments, what you should do is you should see this tip. They are going to keep you only Babcock's forceps. They will keep you Babcock or Alice or Cocker. Only these 3 instruments are commonly kept instrument. Babcock instrument, the tip will be like this. Okay, the tip will be blunt tip. You can use to handle the bowel. Alice will have sharp tip like this. Cocker will have single tooth only. Alice is having multiple tooth, whereas Cocker will have a single tooth. These two are used to hold the tissues. We cannot hold the bowel. Alice and Cocker, we cannot hold the bowel. We can only hold the tissues. So this is a curved artery forceps. You see, this is a curved artery forceps used to hold a bleeding artery. This is an artery forceps. It will be like this. You should not get confused with this. So this is an artery forceps. So Cocker's forceps will have single tooth, Alice will have multiple tooth, Babcock's will have no tooth like this. Okay, so this is how we identify the instrument. Definitely there is going to be a question on instruments for you. And I am seeing the past few exams in FMGE, everywhere they are asking question on some swellings in the body. So naturally, you know, swellings in the body are simple questions of MBBS level. So many of you might be having some small lipoma, some of you might have sebaceous cyst. So you should know how to identify the swellings. So now the first important swelling here, this is a repeat MCQ. In this swelling, if you see, there is a punctum. Okay, this is a punctum. Punctum is an opening of sebaceous duct that gets obstructed, resulting in retention cyst known as sebaceous cyst. So retention cyst known as sebaceous cyst. My question is, sebaceous cyst is common in which place? Means it is common in scalp. Okay, it is common in scalp, or it can happen in anywhere, but it is not seen in which place? Sebaceous cyst is not seen in palms, soles and mucosa. So palms, soles and mucosa, you won't see sebaceous cyst. If you are seeing a sebaceous cyst in the mucosa, it is known as Farday's disease in the lips. Farday's disease is the lips. The sebaceous tissue in the lip is known as Farday's disease. So please remember, sebaceous cyst, highly expected image based question for your exam. So this is a question, again, a huge swelling. Whenever you see a huge swelling, please think of lipoma only. Please think of only lipoma. This is a lipoma shown here, which is seen in the nape of the neck. So there is, this is not the exact image kept in the exam, but the skin will be normal. Okay, skin will be smooth. Smooth or bocillated. Bocillated means it may look like some lobulated like this. If this is swelling, means it may look like this, some bocillations may be there. So lipoma is an universal tumor. It can happen anywhere. It can happen anywhere. Can somebody tell me what is Dercum's disease? What is Dercum disease? Dercum's disease can be asked in the exam. For your exams, it can be asked. So there is some fellow don't have any time, no other work, it seems. He's continuously posting, and I don't know, the DocTutorial guy is not even blocking that fellow. He is very much interested in showing something, it seems. They have to block such people. So they don't know the seriousness. There are some people just come and play in the life of the medicos. So already students are very much stressed and sleepless for the past few days or the past few months with the nearing of exams. So they should have a basic courtesy. We should not go and disturb such type of classes. What to do? So they are people like that. So today from the morning we could see there is a huge gunshot in US. So many children are killed. So many people are becoming psychoic like that. What to do? So the psychiatric people need special treatment. They need a special centers to be opened. That is a problem. They should block, actually, the DocTutorial people, the administration, I don't know what they are doing. They should come and remove him or block him during the chat. So now let us come for the class. This is a lipoma. So lipoma is a universal tumor. Derkham's disease means what? Very good Aliya Khan. Very good Arman. That's a multiple lipomas all over your body. Multiple lipomas all over your body is known as Derkham's disease. So this is a simple picture of lipoma. So you just analyze how the questions are being asked. When we are discussing the questions, you can see they are not asking anything deep or anything what you have read and mug up so much. It will be simple clinical question only. So they won't ask anything so tougher or which is to be coming from your deep memory. Nothing is needed. If you understand the concept, you can answer all the questions. In hypovolemic shock, we are doing a resuscitation. Which organ should be assessed for determining underperfusion? Simple. This question is a one-liner question. Investigation of choice to assess the adequacy of resuscitation. What is answer? Adequacy of resuscitation in a shock patient is assessed by means of urine output. The question is very simple. It is on urine output. The question is on urine output. So the answer is kidney. We have to assess the organ kidney. So the best clinical method to assess the adequacy of resuscitation is urine output in a shock patient. So this is a simple question on shock. So I might be appearing like little going fast, but please gather the questions and answers. My aim is I want you to read these 200 questions near exam and remember them for exam. So just in this 2 hours, I am going to cover 200 questions. All these questions are repeat questions, high yield areas, definitely will be useful. They may again be repeated in the exam. A lady with a 50% of burns of dermis and subcutaneous tissue came to emergency department. What is the classification of this burns? Very simple question. What is the classification of burns? Let me draw the picture of the burns, normal skin. So this is epidermis, and this is dermis. Dermis is of two types. This is papillary dermis, this is reticular dermis, and then comes subcutaneous tissues. This is subcutaneous tissues. If the burns is up to epidermis, it is first degree. Up to superficial papillary dermis is second degree superficial, or up to reticular dermis is second degree deep. When it goes to the subcutaneous tissue, it is third degree or full thickness burns. It is known as third degree or full thickness burns. It is not second degree deep. Dear friends, it is not second degree deep because the burns of subcutaneous tissue is mentioned. Subcutaneous tissue is third degree burns. Second degree deep burns will be up to this reticular dermis only. It will not involve the subcutaneous tissue. When the subcutaneous tissue is involved, it is third degree. There is one more degree known as fourth degree burns involving the muscles and bone. Usually seen in electrical burns. Okay, that is fourth degree burns. Cellulitis. Cellulitis is a, what is cellulitis? Cellulitis is an inflammation of skin, subcutaneous tissue and underlying fascia. Which is correct in this? Among this, which are all involved by cellulitis? Cellulitis involves subcutaneous tissue and underlying fascia. Underlying fascia. Skin will be looking normal. Skin will be looking normal. Please remember, it mainly attacks the subcutaneous tissue and the underlying fascia. So it is a non-suppurative invasive lesion. Please remember, non-suppurative invasive lesion. Suppurative means they will form pus. There is no pus here. It is a non-pus forming inflammatory problem of the subcutaneous tissue and underlying fascias. Please remember, if there is an inflammation of the skin and subcutaneous tissue, it is known as erysipelas. These are all actually very basic questions. Erysipelas is an inflammation of the skin and subcutaneous tissue. Subcutaneous tissue and underlying tissue is known as cellulitis. So please remember this. Both are caused by staph. Both problems are caused by staphylococci. Staphylococci involving skin and subcutaneous tissue is erysipelas. Subcutaneous tissue and underlying tissue is cellulitis. Okay, is known as cellulitis. It is a non-suppurative and invasive tissue. It's taken from surgery 6, sir. So 40 years old patient with the femur fracture with the pulmonary infiltration and respiratory distress. So very simple question. This is a direct ortho question. When there is a fracture, big bone fracture, long bones or major bone fracture, there will be naturally fat embolism causing respiratory distress. So simple clinical question. There is nothing needed to explain this. They are not going to ask you anything beyond that. Simply they will ask you to diagnose a problem. That's all. They want that. What the examiners expect is, as a foreign medical graduate, you should know what complication can happen in various diseases. That's all. That is all. That's a simple question on fat embolism. 32-year-old man presented with fever and pain in the upper right hypochondrium after food intake. So, fever and pain in the upper right hypochondrium after food intake. What is the investigation of choice? What should be done? What should be done? Investigation of choice. So, you suspect here acute cholecystitis. So, acute cholecystitis or a gallstone related acute calculus cholecystitis. So the answer here is very simple. The ultrasound is enough to diagnose acute cholecystitis. Actually, this question is a hepatopapillary question, came wrongly here. But please remember, patient coming to you with the fever and right hypochondrial pain, you should think of acute cholecystitis. Especially after food intake, it is more in chance of gallstone getting occluded at the cystic duct. Okay, simple ultrasound is answer for this. So here comes a trauma question. So hereafter you will see most of the concepts will be repeated. See, FMGE 2019, the two papers we are discussing. Unconscious patient, most common cause of respiratory obstruction. I told you, when we are doing primary survey, A, B, C, D, E. So airway, first is airway should be looked out. The most common cause of airway obstruction is own tongue falling backward. Okay, tongue falling backward. So we will discuss it when the question, I am telling you, if you have doubts, please note it. We will discuss it when such concept coming, Vincent. We will be discussing about those differences when the question comes, when we discuss about the appendicitis. So airway is because of the tongue falling backward. When the tongue falls backward, there will be airway obstruction. That is the most common problem. That is the reason we do some maneuvers like chin lift, jaw thrust, and apply so you have to do the chin lift, jaw thrust, and you can apply a Guidal airway to prevent tongue falling backward. So Guidal airway, jaw thrust, chin lift are the maneuvers you should do to prevent tongue falling backwards. To prevent tongue falling backwards, we should do these maneuvers. Chin lift, jaw thrust, and Guidal airway are the maneuvers which are done to prevent the tongue falling backwards. In an accident case, after arrival of the medical team, all should be done in the early management, means in primary survey. You can see how the same concept is repeated in various forms. Same question is repeated in various forms. So here again, in a primary survey, what is not done? So we have to stabilize the cervical vertebra. So as a part of airway, we put a cervical collar. Breathing is checked by respiration, circulation checked by BP, and then only comes disability scoring GCS. So yearly in this A, B, C is done. D is the fourth one. So among this, all should be done in yearly management except Glasgow Coma Scale. Glasgow Coma Scale is done in primary survey, but it is the fourth one. So you should understand A, B, C, D, E. Exposure is the last one. So you should understand this order. Exposure is last. So first what you should do, I should ensure the airway is good by putting all these things and putting a cervical collar, and then I should look for breathing by seeing the respiration, and I should look for circulation by checking the BP pulse. All this comes in an order. Okay, this is coming in an order. Patients are categorized on the basis of chances of survival in disaster management is known as. See, NEET PG questions are different. You will not be expecting the same questions. I will be discussing NEET PG 2022 questions after 3 days, but those questions are totally different. They are more in depth and more clinical. But FMG questions are very superficial clinical questions. You can see this is a simple question on disaster management. When there is a mass casualty, how will you categorize the patient? Simple question. Answer is triage. So see the questions. These are all questions you should never make mistake. If you make mistake, there will be very risk. Okay, so please remember, triage is the answer for this question. So long-term diabetic patient with the blisters walked barefoot few miles on hot sand. He presented with this clinical condition. What is this? This is a gangrene of the skin. Gangrene of the skin. Similarly, the gangrene of the scrotum is what we call it as Fournier's gangrene. That question is asked in NEET PG 2022. Frothiness gangrene. Same way, the gangrene of the skin is known as necrotizing fasciitis. Necrotizing fasciitis. Necrotizing fasciitis is a infection caused by beta hemolytic streptococci. Beta hemolytic streptococci causes this problem, which will cause complete necrosis of the skin and subcutaneous tissues, and we have to excise this tissue, commonly seen in diabetic patients. Such type of necrotizing fasciitis in the abdominal wall, can you tell me what is the name? If it is seen in the scrotum, it is Frothiness. If it is in the abdominal wall, what is it known as? What is it known as if it is in the abdominal wall? Please tell me, what is it? That is Melanese gangrene. So Melanese gangrene is in abdominal wall. In the scrotum, it is known as Frothiness gangrene. It is known as Frothiness gangrene. A man was presenting to the emergency department with a head injury after an accident. Investigation of choice should be. So what is the question? Simple. The patient is having a head injury. How will you find out whether he is having a head injury or not? Simple question. What is the answer? Yes, anybody has very good Pragya and Arman. That is correct. It is a Melanese gangrene. What is the answer for a patient who is having a head injury? Answer for head injury, answer is, please remember, it is non-contrast CT. We don't take contrast CT for a head injury. In a non-contrast CT, the hemorrhage looks bright. The hemorrhage, when there is an EDH, the EDH, that blood will look bright. That is known as hyperdense. We are going to see such images. I'll show you non-contrast pictures soon. So EDH will look hyperdense. So the answer is non-contrast CT. 21 years, so we have completed the FMGE 2019 basic questions. Now you just think you are an exam going student into 2020. You are going for exam in 2020. See the questions now. 40 years old female with severe cardiac tamponade, another high yield area. Like tension pneumothorax, cardiac tamponade is a high yield area. She had to undergo an operation for which surgeon gave clearance. Which of the following surgery must not be done? So she needs to go hysterectomy. Hysterectomy is planned. So total hysterectomy, subtotal hysterectomy, vaginal hysterectomy, all these are done by spinal anesthesia itself. Just with a spinal anesthesia, we can do it. But for a laparoscopic hysterectomy, I need general anesthesia, which is impossible in this patient as it is a patient of cardiac tamponade. So answer is very simple. It is laparoscopic hysterectomy cannot be done. Cutaneous horn as shown in the image is associated with which of the following cancer? So it is a complication of sebaceous cyst. Sebaceous cyst becomes dried up and becomes a sebaceous horn. This fellow will go for a cancer, squamous cell cancer. Sebaceous cyst will lead to squamous cell cancer. Remember that. Okay, it can lead to squamous cell cancer. So this question is an AIIMS question, which after the AIIMS exam, the next exam itself, it was asked in FMGE exam. So this is a question showing on FAST. In FAST, which of the following needs immediate laparotomy? These are zones known as retroperitoneal zones. These are known as retroperitoneal zones of hematoma. Please remember, retroperitoneal zones of hematoma. Following a blunt trauma, patient can develop hematoma in 3 zones. Zone number 1 is injury from aorta or IVC. Aorta or IVC injury is zone 1. Zone 2 is kidney injury, renal injury. Zone 3 is pelvic hematoma. Pelvic hematoma. So there are 3 zones now patients may have an hematoma. So in which of these zones will need immediately we have to shift the patient for surgery? Not needed for renal or pelvic hematoma. No need of emergency surgery for 2 and 3. But for injury of aorta and IVC, immediate laparotomy should be done. To expose the aorta, we do a maneuver known as Mattox maneuver. Mattox maneuver. To expose the aorta, we rotate the structures from the left to medially, that is known as Mattox maneuver. For exposing the IVC, we do a maneuver known as Kettle maneuver. Please remember, Kettle's maneuver. Kettle's maneuver is done for patients who are having a thing on the right side. So right side exposure of IVC, we do Kettle's maneuver, and aorta Mattox maneuver. So IVC and Kettle IVC exposure is kettle, iota exposure is Metox maneuver. So please don't forget, these maneuvers are very important maneuvers for exams. Okay, so this is a point. Zones of retroperitoneal hematoma, there are 3 zones. Zone 1 is injury of aorta and IVC. Zone 2 is an injury of kidney. Zone 3 is an injury of pelvis, pelvic hematoma. Okay. 60-year-old woman, known case of lung cancer, complaints of shortness of breath. So please understand, when you are reading a bigger questions, don't get tensed up. It will be a simple question. You should not get stressed. Just read it very gradually, slowly, understanding the question. So her neck veins are engorged and her JVP was elevated. Heart sounds are muffled. The catch point is here. Heart sounds are muffled and breath sounds appear reduced on the right side infrascapular area. So please remember, heart sounds are muffled, breath sounds are reduced on the right side infrascapular area. Requisition for chest X-ray is done and is shown below. Comment on the diagnosis of the patient. So this is a case of, okay, this is actually, sorry, the image is missing here. The image is shown here means, so this question is heart sounds are muffled. So please remember three triad here. What is Beck's triad? What is Beck's triad? Beck's triad is made up of raised JVP, number 1. Number 2 is muffled heart sounds, muffled S1, S2 and low BP. So these are the 3 points you should not forget. These are 3 points are classically seen in this case. Elevation of JVP, heart sounds are muffled and breath sounds appear reduced on the right side, maybe due to the lung cancer. That is a point you should know here. Maybe due to the lung cancer on the right side, she might be having a reduced breath sound. X-ray chest is done and that is actually showing an appearance that is known as ice bag appearance of cardiac tamponade. So ice bag appearance of cardiac tamponade will be shown in this case, and that is therefore a case of cardiac tamponade. C is cardiac tamponade. So please remember, muffled heart sounds, hypotension and low BP is Beck's triad. So this is the next question. On a post-op second day, X-ray of the patient was obtained. Patient is not complaining of any respiratory distress and is comfortable in the hospital bed. On auscultation, equal air entry is heard. What is the next step in the management of this patient? So in this case, if you see, there is a mild pneumothorax on the right side. Please remember, there is a mild pneumothorax. Pneumothorax is present on the right side, but left lung is normal. What will you do now? So the question will stimulate you to go and put a needle or go and put a thoracostomy. So please remember, on a second post-operative day, especially following any laparoscopic surgery, you can develop carbon dioxide pneumothorax. Nothing to worry, that will get absorbed by itself. So wait and watch and give supplemental oxygen if required. Simple question. To make you confused and make you wrong, they make a question like this. You should not put a needle now. Don't put ICD. No need of intubation because patient is comfortable. That is, equal air entry is heard is actually will not be a correct answer because this image might have little decreased air entry on this side. So probably the image in the exam would have been given small amount of pneumothorax here and there will be lung shadow will be present on the right side also. So this is a case of asymptomatic pneumothorax following a laparoscopic surgery. No need of anything, just wait and watch. That pneumothorax is not by air, it is by CO2, it will get absorbed by itself. So elderly patient fell in the bathroom in the early morning hours and became unconscious and was rushed to the casualty. On arrival, GCS is 9/15 and urgent NCCDC non-contrast CT was performed. Comment on the diagnosis. So this is an image showing you the hematoma, hyperdense, appearing like this. What is this? It is a concavo-convex hemorrhage known as SDH, subdural hemorrhage. It is due to bridging vein damage. It is due to bridging veins getting torn up. You get this subdural hemorrhage. So definitely you are going to get one CT scan image of the brain. An elderly patient with hypertension fell down in his bathroom. His BP was 210/110, 220/110. Which of the following statement is correct about this patient? Which is correct about this patient? So a patient has an hypertension and falling unconscious means he had a intracerebral hemorrhage. That is most probably due to putamen hemorrhage. You know, this is a medicine question. It is not a surgery question at all. It is a putamen hemorrhage. Patient will land up with a CVA. So this is a putamen is the common site. Start antiplatelet drugs. Platelets are transfused if platelet count is not low. These are all to confuse you. Unwanted choices. Reduce the BP to 120. It is all not needed. Here the patient, which is the correct answer in this, the question is putamen is a common site of bleeding in an hypertensive patient suddenly falling down. Okay, suddenly falling down, the patient will have putamen. We will reduce the BP, but correct answer, best answer here is putamen is a common site of putamen hemorrhage. Okay. 30-year-old car driver involved in accident. He is brought to emergency room with the complaints of breathlessness. See, again and again you will get the same concept only, breathlessness. On physical examination, pulse rate 110, BP 90/60, temperature 37 degree, extensive bruising noted in the right side of the chest. Urgent bedside X-ray was done. What is the best management of this case? So this is a case of, here the patient is having pulse rate elevated, BP low, breathlessness. Probably the patient is having a pneumothorax. What is the best management they are asking, not the next management. There is a difference between next and best. Next means needle. I will put a needle in the second intercostal space for a pneumothorax. But best means ICD is the best. So you go for thoracostomy or thoracotomy. The answer is thoracostomy is not the answer. So the thoracostomy is the answer. Thoracotomy is not the correct. Intubation is not correct. Fluid resuscitation is not correct. We have to put a thoracostomy tube. That is nothing but ICD tube. So the answer here is putting an ICD tube is known as thoracostomy tube. So needle is the next done, but next done is not asked. They are asking what is the best done. So best done is thoracostomy with an ICD tube. Okay. So this question came in the NEET PG exam and every student got confused in the exam because the best treatment for tension pneumothorax. What is the answer? Best treatment is always putting an ICD for any tension pneumothorax. What will you do? Next is I will put a needle thoracostomy will be done, followed by immediately I will arrange for ICD and I will put an ICD. Needle is only a temporary procedure. After putting a needle, I will plan for an ICD. Please remember, carry home this concept for your exams. Okay. So this question just now I discussed. Patient develops a lesion 6 months after surgery. Diagnose the condition. Classical scar, that is keloid, extending beyond the normal skin area. So like this, I'm telling you, the concepts will be repeated. If I am going though I'm telling 200 questions, you might be scared. How is he going to discuss 200 questions in 2 hours? We will be discussing, you will be answering, because most of the questions will be repeated again and again. So identify the instrument. See, I am now discussing 20 FMGE questions. In 2019, they asked about artery forceps. In 2020, they asked about Babcock's. So every year they ask the same question only. They are not asking anything different. They ask the same area just with a small twist, nothing else. So this is a Babcock's tissue forceps. See again, next question. A player injured with a ball and suddenly lost consciousness when one of the teammate comes for helping. See, understand this catch point here. He gets up by himself and starts playing. Very interesting. After a head injury, he gets up by himself and starts playing. During the tea break, the person was again unconscious while his friend saw him. Immediately was rushed to the hospital. What is the diagnosis? So this is what we call it as lucid interval. This phenomenon of lucid interval is a feature of extradural hemorrhage seen in middle meningeal artery rupture. Middle meningeal artery rupture, you get this feature of EDH. So this is again a classical basic question from physiology. Which fluid is not advised during intracranial head injury? Intracranial head injury, which fluid should not be given? So please remember, in intracranial head injury, there will be increased intracranial pressure. Our aim is to reduce the intracranial pressure. So the best fluid therefore is mannitol. Mannitol is the best fluid to reduce the intracranial pressure, to decrease it. So okay, if mannitol is not available, we can also give normal saline or oral or even hypertonic saline. When you give these fluids, they will not cause edema in the brain. But when you give 5% dextrose, it is an hypotonic fluid. Please remember, it is an hypotonic fluid which will go inside. It is an hypotonic fluid which will go inside and it will reduce the serum sodium and increase brain water and increase intracranial pressure. So hypoosmolar solutions such as 5% dextrose in water will reduce serum sodium and increase brain water. So it is highly contraindicated. Hypotonic solutions are contraindicated in head injury because already patient is having high intracranial pressure. We have to reduce the pressure by giving hypertonic fluids or osmotic diuretics. Here comes the familiar favorite question of national board examiners. A patient was brought to emergency, immediate IV transfusion has to be done. His BP is 90/60, pulse rate 110. Which color cannula has to be given for maximum infusion? Maximum, the question is asking maximum. So there are three important cannulas you should remember. First one is orange, which is 14G. Then gray, which is 16G. And it is 18G, which is green. These are the three commonly available cannulas in a trauma center. Please remember, three cannulas in trauma center is this. These three cannulas are not used in trauma. You should use only 14, 16 or 18. In fact, 14 if it is available, that is the maximum infusion can be done. Minimum what can be used? Minimum I can use 2 green venflans. On either side put 2 green venflans. It will infuse 85 ml per minute. The fluid which can go in green venflan is 85 ml per minute. Is a repeat question. So the answer here, best answer is orange. Orange is 14 gauge cannula. So cannula is a favorite question for national board examiners overall. Definitely you will get questions from cannulas. IV cannulas, please don't forget. So best method to check the correct position of central venous catheter. Here comes a very interesting favorite question of national board examiners again. So all of you know very well, central venous catheter can be inserted into the subclavian vein or into the internal jugular vein. Two methods you can insert. Wherever you insert, the tip should be there where? Tip should be there in the SVC. Tip must be in the SVC, not in the right atrium. If it is in the right atrium, patient may develop. If it is in the right atrium, patient may develop thrombosis. So please remember, IJV subclavian vein are the two veins we put in. The tip should be in the SVC is confirmed best by taking an X-ray chest. See, this is a wrongly placed catheter. Can you see? The subclavian catheter is inserted. Instead of it is going like this guy has gone inside like this. So it is a wrongly placed catheter. So this is a wrongly placed catheter. So the wrong malposition of central line can be detected with the help of X-ray. So X-ray is the best answer for finding out the position of catheter. So what is a dangerous complication of putting a central vein? What is a dangerous complication after putting a central vein? That is tension pneumothorax. We may injure the pleura. It is very common with subclavian vein. Tension pneumothorax is a very dangerous complication. It can happen with subclavian vein. Okay. So maximum infection. There are many questions in central vein. If I start taking central vein catheter, it will take more than half an hour to 1 hour. So central vein catheter, the dangerous complication is tension pneumothorax. Infection is common with which cannula means femoral vein catheter, it is common. In a trauma, which central vein we use means IJV is used. For a elective cases, which one will you use means subclavian vein I will use. Like that, there are so many questions. So many questions. The point is the tip should be there in the SVC, which is confirmed by X-ray chest. Okay. We cannot read and discuss everything at this point of time, especially with 10 days before exam. We just see the essential questions and the concepts. You will definitely answer the exam. 25 questions you are going to guarantee answer from surgery. 25-year-old male patient, trauma center, presented with a BP 80/40, respiratory rate 25. On examination, there is hyperresonance. See the question again. Hyperresonance means it is pneumothorax. See how much I get fatigue of answering these questions. So many times that question was asked. Chest X-ray was done. What is the appropriate treatment? This question is a classical question I told you from ATLS manual. So wide bore needle in the 5th intercostal space followed by ICD. This is the correct answer. I don't know why people wrote A in this exam. Many of them wrote A in the exam. So the answer idea they are not asking what is next. They are asking what is the best. The best is put a needle and put an ICD. Okay. Put a needle, arrange ICD and put it in next 10 to 20 minutes. That's all. See another question on swelling. See in the whatever we saw a sebaceous cyst, lipoma. Now it's a dermoid cyst. Dermoid cyst is seen at the lines of fusion of bones. External angular, post auricular, scalp. Everywhere you get dermoid cyst. external angular, post-auricular, everywhere you get dermoid cyst. Dermoid cyst is treated by surgery, not by anything else. Dermoid cyst means it's surgical excision only. The catch point to say it is a dermoid cyst, what is the answer? The catch point to say it is a dermoid cyst is if you palpate, there will be bony indentation. The bony indentation will be there. That is a catch point to say it is a dermoid cyst. Bony indentation will be seen. Okay. See, simple image question. Simple image question. Just image and simple clinical scenario. Identify the clinical condition based on the image shown below. It is seen in diabetic mellitus patients. It is caused by staph aureus. Again, it is known as carbuncle. Carbuncle is seen in nape of the neck, full of inflammation. Pus will be pouring out. It's a infection seen commonly in diabetic patients. Uncontrolled diabetic patients will get this. So FMG December 2020 was one of the easiest paper I have seen. Identify the procedure shown here. It is tracheostomy. So this is simple tracheostomy. The tube put inside is cuffed tube. It's a cuffed tracheostomy tube shown here in the image. 39th question. A bedridden patient post-surgery developed low-grade fever, pain and pedal edema on day 5. Please remember, post-operative patient, low-grade fever, pain, pedal edema on day 5. What is the most likely diagnosis? Yes, what's the likely diagnosis? Post-operative fever. The causes on first post-op day, second day, third day, fourth day, fifth day, sixth day, seventh day. I used to remember simple method A, B, C, D. 5 looks like yes, it is surgical site infection. 6 is burst abdomen. When you hit a 6, the crowd will burst abdomen. 7, there is a leak from the anastomosis. So when you are leaking in anastomosis, you will go to heaven. Remember 7, you go to heaven. So 6 is burst abdomen, 7th day fever is leak, 5th day fever is surgical site infection, 1st day fever is atelectasis of lungs, 2nd day is bladder infection, UTI, 3 is cannula, Venflan infection, cannula infections, D is DVT. So 4th day the cause of fever is DVT. So the best answer here is on a 5th post-op day, means it is after 4 days the patient coming to you with the pain and pedal edema. It is more characteristic of DVT. Okay, it is more characteristic of deep vein thrombosis. A patient sustains RTA and brought to emergency department where he is found to have a pelvic fracture and there is a blood at the tip of meatus. So pelvic fracture with the blood at the tip of the meatus. What is the next step in the management? What is the next step in the management? Okay, the next step in the management is, this is actually a urology question. You should put a SPC. We should not try to put a Foley's catheter. Don't put Foley's catheter as the answer for urethral injury. We are going to discuss this question again. So urethral injury, we will put a Foley's catheter is wrong. We have to put a suprapubic catheterization. So this question is a urology question. It will come back again. Don't worry. So FMG December 2020. So many questions on shock. The type of shock in a patient who has profound bleeding and CVP less than 5. So please remember, CVP normally is 8 to 10 centimeter water. That is a normal CVP pressure, 8 to 10 centimeter water. If it is more than 10 centimeter water, it is cardiogenic shock. Okay, it is cardiogenic shock. If it is less than 5 centimeter water, it is hypovolemic shock. Okay, it is hypovolemic shock. So the answer here is hypovolemic shock. Simple answer. The CVP is falling down in hypovolemic shock. If a patient requires emergency surgery to survive, no attenders are available to give consent. Simple question. So a patient is coming to you, he is having a trauma. We need to operate immediately. There is nobody to give consent. Yes, what will you do? We'll operate without consent. There is no need of getting consent from anybody. No need to get consent from any hospital authorities or from anybody in the hospital, any attenders. You can operate by yourself without any consent for the benefit of the patient. Okay, no consent needed if nobody is available. CVP is raised. See, December 2020, there is a question on CVP low. In December FMG June 2021, there is a question on is raised in which of the following shock? Answer is raised in cardiogenic shock. Now you can understand why I am doing a repeated session in expected question series. In expected question series, I am doing only the repeated questions because The expected questions, all the questions are going to come only from the previous repeat questions only. So you are going to answer all these questions correctly in the exam by listening for this 2-hour session. Okay. Chronic smoker was undergoing major surgery under general anesthesia with oxygen and nitrous oxide. Suddenly he collapsed on table. Breath sounds are not heard on the left side. Another question on pneumothorax. Why this is a pneumothorax? Please understand, when you are using general anesthesia, then the positive pressure can cause rupture of the bulla. Please remember, rupture of the bulla in the lungs can get ruptured, and that will cause air leaking outside, and that's a case of tension pneumothorax. Immediately you should put ICD, otherwise the patient will die. Okay. Patient presents with head injury and increased intracranial pressure with a low BP. Head injury, increased intracranial pressure, decreased BP. Please remember, in a head injury case, increased intracranial pressure is the first thing we should concentrate, and we should give them mannitol. Which drug should be given means the drug is mannitol. Which drug should not be given means prednisolone and dexamethasone should not be given. Please remember, steroids are contraindicated in trauma. In trauma, you should not give steroids. Steroids can be given in cancers, in the brain causing, we can give steroids. In a cancer causing increased intracranial pressure, we can give steroids. So steroids, prednisolone and dexamethasone are highly contraindicated, and we can use furosemide, but the problem here is low BP, so I cannot use furosemide. If the BP is okay, I can use furosemide. Simple catch point. Every question is a clinical question with some catch point. So low BP, so I cannot use furosemide. A patient presented to emergency after blunt trauma with a low blood pressure. What should be the initial step? So simple question, A, B, C, D again. A, B, C, D, E. So blunt trauma, low blood pressure. What should be the initial step? Airway. Is there any airway? No, it is not mentioned. Breathing, it is not mentioned. C, start resuscitation with IV crystalloids. That is the correct answer. Then only we will plan for laparotomy or what. First you start them with IV fluids. That is the third step. Okay, if IV fluids are available, you give that first. After that, you go for blood. Then, if the patient is still unstable, you go for E-fast. Before taking him for surgery, we will be doing E-fast. E-fast will be done. Then only we will go for laparotomy. So, no confusion in the clinical management of trauma cases. Please remember this point. A patient following RTA was brought to the hospital with a high heart rate, very low blood pressure and respiratory rate more than 22 per minute. What should be the next step in this patient? High heart rate, low BP, respiratory rate more than 22. What is the next step? A, B, C, D, E. So next step is airway intubation. Simple. That is the first important next step. So patient with RTA, high heart rate, low BP, respiratory rate. So we don't know what is the injury. We don't know what is the problem. So first what you should do, follow the airway protocol. Airway, breathing, circulation, disability, exposure protocol. So the answer here is airway. Not fast. Fast is not the answer here. Airway is always the first. So another question on head injury again. See, GCS question will come definitely. Was able to open his eyes on painful stimuli. So E is 2. Withdrawal. Obey localites with flexion extension now. So withdrawal is motor 4. Inappropriate words. 1 confused word sounds nowhere. So these are the 5 points. 1 confused word, inappropriate word. Verbal 3 point. Unless you remember this mnemonic, you will get confused and you forget the concept there in the exam. So what the mnemonic I told you, please don't forget it. Okay. E2, V3, M4 is answer for this simple GCS calculation score. See another question on GCS. A patient with head injury was brought to casualty. GCS 12 CT was taken. What is your diagnosis? Simple question on EDH. See, the questions are very simple. FMGE exam, don't worry about the percentage which is shown last year. So don't worry, oh, last year only 25% of them only passed. 75% failed. So I also may not pass. I may fail. So because this fear of failure of 75% is the main reason for failure of FMGE students. If you all are going to work sincerely and go and attend the exam with a cool mind and a fresh heart, I am sure the result will be 75% pass and only 25% will fail. So don't worry about the previous year results. Don't worry about the people scaring you. The result is always less. It doesn't mean if you are having confidence in your preparation and you are going to go with the concepts of all the topics, definitely you are going to get only 150 needed out of 300. Easily you can get 170, 180, 200 plus you can get if you go and answer the questions with full free mind. Okay, don't have any prefixed thoughts in your mind. For example, you might have a prefixed thought, oh, I have not completed anatomy, I have not finished biochemistry, I have not finished medicine, so I may fail. Don't worry, it doesn't mean you have to complete all the 19 subjects. If you are strong in only 8, 9, 10 subjects, you can definitely pass. Strong in 10 subjects, you will pass. So don't worry about some subjects not prepared, not revised, or you are not strong in the concept. Don't worry. So answer the questions in such a way which you are very well versed with answers. You can answer them. So there is no one going to cause any trouble by not preparing for exam. There is nobody going to fail you because you have not prepared medicine. Without preparing medicine also you can pass the exam. This is not a competitive exam. Please remember, this is a qualifying exam. Read less, remember more. That's the concept. Okay, reading more and remembering less is totally the wrong concept of preparation. Read less, remember more, and crack the exam, clear it, and then come for competitive exam. At that time you can read more and more. Okay, so 25 years male after massive RTA was brought to the casualty with breathlessness, tachycardia. See again the same question, tension, pneumothorax. So last year and all some 40 questions came from surgery. So please remember, the surgery is one of the major subjects. You should never make an excuse in preparation. Surgery, medicine, OG, with only 3 subjects, I am telling you, you can pass the exam. You can pass if you are thorough with these 3 subjects, medicine, surgery, OG. You will get at least 100 plus questions in this, and you have applied questions of anatomy, physiology here and there from medicine, surgery and OG. You can easily crack. Last year 35 to 40 questions came. The patient who had burns some years back now presents with ulceration over the burns area. Again another old concept, indicative of malignancy. A burns scar can go for what malignancy? It can go for Marjolin's ulcer, which is a squamous cell cancer. Okay, Marjolin's ulcer, which is a squamous cell cancer. A patient suffered from blunt trauma to the abdomen and was brought to emergency room. He is unstable. You are the doctor. Basic resuscitation is done and IV fluids are given. Fast is positive. Fast positive. Not improving despite IV fluids. Next step is, there is no excuse if you make mistake this type of question. The answer here is laparotomy. So let me tell you the protocol for blunt trauma protocol. This is a definite MCQ for your exam. A patient coming to you with a blunt trauma. Next important thing you should do is E fast. On one side, ABCD is going. Okay, ABCD is going on one side. What investigation you should do is E fast. E fast is positive. What should I do? I should see whether patient is stable or unstable after resuscitation. After resuscitation, patient is stable, I will do CT scan. If unstable, I will take him for laparotomy. Do you have any doubt in this protocol? This is the smallest of all the protocols you read in surgery. You read in surgery, the smallest protocol is this. So laparotomy is done for unstable patients. Stable patient only I should take CT scan. If you are mentioning CT scan, you are not understood the concept. You should only answer as explorative laparotomy. Laparoscopy is not done for trauma. Okay, it is exploratory laparotomy. Alcoholic patient who is diagnosed with chronic hepatitis has been admitted to emergency room for vomiting of blood since last 2 days due to variceal hemorrhage. Patient is in shock. You are the doctor and you have started the first line treatment, but the patient died. What is the underlying cause of death? So this is simple question. Don't worry about whatever given here. Patient died of hemorrhagic shock. Okay, hemorrhagic shock. Lossing of blood, he got, yes, don't worry Vijay, you had an opportunity to prepare again and strengthen the concepts for your NEET PG, and this time you will crack more than 249. So don't worry. So whatever you answered, this is a December 2020 question, the answer is here, hemorrhagic shock. Patient died of bleeding. Hemorrhagic shock is a type of hypovolemic shock. Patient was brought to emergency in hypotension with the cold extremities, BP 90/60, most likely cause. See, whenever you see a patient with a shock, there are 2 methods. So just give shaken to the patient. If the patient palms are chill, it is hemorrhagic shock. It is warm, it is septic shock. So patient is having a simple catch point, cold extremities, it is hypovolemic shock or hemorrhagic shock. The same patient had a warm extremities. My question answer would have been septic shock. Septic shock. Here the best answer is hemorrhagic shock. Okay. So I want to tell you there will be only 3 shocks asked in your exam. 1 is hemorrhagic shock or hypolimic shock. 2 is septic shock. 3 is cardiogenic shock. Cardiogenic shock is also a medicine question. In surgery, we will get questions only from hemorrhagic shock and from septic shock. Okay. A patient was brought to the emergency with hypotension, raised JVP, heart sounds muffled, neck veins enlarged. He died in the hospital and autopsy was done. Following image obtained. What is the diagnosis? See, do you need any explanation for this? This is a case of cardiac tamponade. We have opened the pericardium. You can see the patient died of cardiac tamponade. So everything is already clear. Okay, simple question. Lucid interval is seen in EDH. So the December 2021 questions are very easy when you have read the previous questions. I am telling you, if you have appeared for December 2021, you can see all the questions are repeat concepts. No new concept at all. So if you are a student who have appeared for December 2021, if you have been failed in that exam, means you have not revised the old questions properly. All the questions are old questions. Not even a single new question. A patient was brought to emergency following a car accident. His blood pressure is 90/60. GCS is 9. He is having visceral injuries. Least likely cause of hypovolemia in this patient. So this question is very clear. So what? The patient is having decreased BP. The patient is in hemorrhagic shock. The simple point is the patient is in hemorrhagic shock. Hemorrhagic shock means he must have lost more than 1 liter of blood somewhere. Yes, he would have lost in splenic injury. He would have lost in retroperitoneal hematoma. He would have lost in lungs, in the chest. But in subdural hematoma, maximum blood loss will be only 200 ml. That's all the space. We cannot lose 1 liter of blood in the skull. So therefore, subdural hematoma will not cause fall in BP. Not cause fall in BP. That is the question. They are asking which among the 4 will have no loss in BP. So subdural hematoma will not cause fall in BP. Central vein line was put in the subclavian and the patient collapsed during insertion of the central line. Diagnosis over. I told you, when I am putting a central line, the most dangerous complication is breath sounds suddenly were found to be absent. On percussion hyperresonance, most likely cause of this patient collapsing is tension pneumothorax, not normal pneumothorax. So please remember, normal pneumothorax is an open pneumothorax, the patient will not die. But tension pneumothorax, patient may die. Be careful. Battle sign is this. In a head injury, middle cranial fossa fracture, bruising on the mastoid process is 100 times asked MCQ. That is battle sign. Pressure to cause pressure sore, bed sores. I hope you know very well. Bed sores are very commonly seen in the paraplegia patients and CVA patients. It is very commonly seen in ischium in the back. Okay, ischium, gluteal, greater trochanter areas, sacrum. In all these places it is very common. It is because of continuous lying of the patient in a same position. The capillary pressures are high and that will go for ischemia. There is a direct line from Bailey. A new question in this exam. So it is 30 millimeters mercury or more, they will develop bed sore. So bed sore is asked in NEET PG 2022 this time. It is of 4 grades, stage 1, stage 3, stage 4. Stage 4, the bone will be exposed. That question was asked in this exam. Stage 4 is nothing but the bed sore has gone very deeper and the bone is exposed. That is known as stage 4. You can get this question again in this exam. Stage 4, bone will be exposed. Same question again. See, I told you, all the questions are repeated. What should be the treatment for the pathology? This is a dermoid cyst, external angular dermoid. Treatment is excision. Same question, repeated as same question. 55 years old male underwent an operation for lipoma. 11 months after surgery, he felt an itching and burning on the operative site where a scar is formed. See the line, limited to the wound. What is the nature of this lesion? See, catch point is here, limited to the wound. It is not extending to the normal skin, it is limited to the wound. Answer is hypertrophic scar. If the same question as mentioned, extending beyond the wound, answer is keloid. So the question here is simple hypertrophic scar. Okay, so that completes the part A. So any doubts you have in trauma or general aspects, please tell me now. So we are going to discuss all the systems one by one. Any doubts you have, please tell me in trauma and general aspects. I hope you are clear with the concepts we have discussed. So if you now you just think about in a fresh mind, what are the concepts being asked? Concepts are asked on pneumothorax, pericardial tamponade, blunt trauma, and simple questions on keloid, hypertrophic scar, swellings. That's all. That's all. General part is over. Though I have discussed 62 questions, there are only 10 questions which are actually repeated again and again on they have beating the same bush. Please remember, they are repeating the same bush, repeating the same question. Okay. So now let us go on to the interesting area in surgery, thyroid, breast and hernias. We are going to discuss now. 27-year-old woman presents with 26 weeks of gestation. Vijiraj, the mnemonic is obey localites with flexion extension now. That is a mnemonic for motor. Obey localites with flexion extension now. That is for motor. For verbal, one confused word sounds nowhere. One confused word sounds nowhere. That is a very important thing you should remember. For the past 4 years from the question paper, there is no question on Burns resuscitation. But if you want, you should know in a Burns resuscitation, there are two methods of resuscitation. One is Parkland formula, another is ATLS formula. So amount of fluid should be given in first half of the fluid is given in 8 hours and remaining half is given in 16 hours. This is common for both. Half the fluid is given in 8 hours, remaining half given in 16 hours. So the volume, how it is calculated means the volume is calculated here 4 into weight in kilogram into total body surface area. In ATLS it is 2 into weight in kilograms into total body surface area. Simple small change. In Parkland it is 4. In ATLS it is 2 for adults. This is for adults. ATLS has for children also. In children it is 3 into weight in kilograms into total body surface area. Children means less than 14 years. So I'm sure they may not be asking you about the formulas in detail, but if at all you want, you remember Parkland formula which is there in Bailey. ATLS formula is not there in Bailey. Okay. A 27-year-old woman with a 26 weeks of gestation with a thyroid lesion which is found to be papillary cancer of thyroid, which is the best treatment for this patient. So the question, don't worry about the question. The question is very simple. It is a papillary cancer. What is the treatment of papillary cancer? Total thyroidectomy is a treatment. That's the answer here. Simple. So, sir, she is pregnant. So, it doesn't mean we should not operate. We can operate during second trimester. Total thyroidectomy can be done. So, the answer here is total thyroidectomy. And radioablation should not be done in pregnancy is another clue. We will not do a radioiodine ablation. Okay, we will do only total thyroidectomy for this case. Okay. Which procedure is done in ranula management? So, ranula is a cyst seen on the undersurface of tongue. We call it as extravasation cyst of sublingual gland. Extravasation cyst of sublingual gland. So, the treatment is excision of the gland, not IND or aspiration. Please remember, many of you might get confused. Ranula is not treated by simple methods. It is treated by major surgery. It is a major surgery. We have to excise and remove the sublingual gland fully. Okay. Most common oral cancer is most common oral cancer. My next question is on most common oral cancer is squamous cell cancer. So please remember, squamous cell cancer in GIT is seen in oral, esophagus and in anus. Yet another oral cancer is seen in oral, squamous cell cancer is seen in oral cavity, esophageal area and in the anus. Another area inside the abdomen is bladder. So bladder is also a squamous cell cancer. So squamous cell cancer is seen in these 4 locations. Okay, please don't forget these 4 locations. So breast cancer related questions are definitely going to come. 2 questions you are going to get in breast. It will be nothing but staging. The question is going to be simply asking you about the staging. So patient has better prognosis in breast cancer. Which patient has better prognosis in breast cancer? Answer is luminal A. This is a molecular classification of breast cancer. Molecular classification of breast cancer based on estrogen receptor, progesterone receptor and HER2 receptor. I will tell you simple method. Remember, luminal A type is the most common type. ER positive, PR positive, HER2 negative. So luminal A type is the most common type. Okay, ER positive, PR positive, HER2 negative. So luminal B. So luminal B, ER B means you should be always positive. B positive. Remember like that. Luminal B means B positive. Okay, B positive. When will you go to the base? You will go to the base when you are very negative, negative, negative. Base means negative. HER2 is HER2 alone positive. Other guys are negative. Worst prognosis is basal type. Best prognosis is luminal A type. No confusion in this. So this question has been repeatedly asked in FMGE exam multiple times. So remember, you will go to the base when you are negative. You will be B positive always. Okay. That's a question, simple question on better prognosis is luminal A type. So this is a very simple practical question. Actually, it's an obstetric question. Mother complains that her baby is not drinking properly from the breast. So the basic point is baby is not sucking the milk out. And now she complains of pain and swelling of the breast. What is the probable condition? So please remember, there is no point mentioned about fever. There is no point mentioned about tenderness. Nothing is mentioned. So very commonly you can see females who are not breastfeeding during the lactational time will get a breast engorgement. They will get a breast engorgement. Okay. They will just get a breast engorgement and they will come to you with a breast engorgement. They have to express the milk out, otherwise they will get pain. Okay. They will get pain. A patient presents with the presence of a thyroid swelling and weight loss. So I am telling you, thyroid cancers are very important for FMGE exam. Definitely one question from thyroid cancer is going to come. So thyroid cancer presenting with the cervical lymph nodes. You should have come to the diagnosis now itself. Can you tell me? Thyroid cancer with the cervical node is papillary cancer. Thyroid cancer with the skull secondaries, pulsatile skull secondaries is follicular. See the question, simple. Cervical node in the same patient decided to go for thyroid biopsy. They have given another clue also for you, orphan nuclei. Do you think this question need an explanation? This is a case of papillary cancer thyroid. Simple question, okay. So please remember, papillary cancer catch points are, PAP-CA catch points are, it will produce lymph node mets, it will produce samoma bodies and orphan nuclei, and it is the best prognosis. It is the best prognosis. All these are essential points you should know about papillary cancer of thyroid. Okay. 45-year-old female came for follow-up post-surgery. X-ray was taken. What is the most likely diagnosis? This is actually a radiology question. You can see here, this is the breast shadow here. The breast shadow is not seen here. So the answer is left-sided mastectomy. So many students marked this as something like emphysema. You should read the question very carefully. They are telling post-surgery follow-up means that is a clue, some surgery has been done. That is a clue of mastectomy. Simple question. There is no need of reading. I am telling you, no need of reading for the last 10 days. You just discuss some concepts with some of your friends. Discuss some concepts, some clinical questions. That is enough to pass the exam. Whatever you are going to read by mugging up the values, score, etc., is not going to come for the exam. They are going to ask you the most practical questions like this only. 45-year-old lady, rapidly enlarging breast lump, firm, mobile on examination with the basilated surface. You see, this is basilated surface. This is a catch point for a Phyllodes tumor. Phyllodes tumor is also known as cystosarcoma Phyllodes. Cystosarcoma Phyllodes. It is not a sarcoma, it is a misnomer. They are known as Phyllodes because on cut section, Phylloid means leaf-like appearance on cut section. Treatment is simple mastectomy. No lymph node dissection needed because it will not cause lymph node involvement. Simple mastectomy is enough for Phyllodes tumor. So after breast cancer surgery, patient comes to you with this finding. This is an applied anatomy question. You guys must know very well. Now when we are preparing for NEET exam, the number of questions from pure anatomy, pure physiology, pure pathology is less than 4 or 5. All the questions are only clinical questions like this. So injury to which nerve causes this winging of scapula? This is a question on winging of scapula. It is Bell's nerve. Long thoracic nerve of Bell causes winging of scapula. So this is not my discussion at all. This is not my question at all. Since it is associated with breast cancer, I have put here winging of scapula is a complication of Bell's nerve. My question is, what is the most common nerve injured in a mastectomy? In a mastectomy operation, which nerve will be commonly injured? It is intercostobrachial nerve. That is my question. Surgery question is this. Okay, winging of scapula is long thoracic nerve of Bell. My question is intercostobrachial nerve is the most common nerve injured in mastectomy, because none of the surgeons we go and injure the Bell's nerve. We always preserve it and save it. Okay. So this is a simple question, but the point is you should be very careful with the image of the hernia. I'll tell you, this is the umbilicus. Okay, this is the umbilicus. This is the abdomen. I'm going to show you some images because every time this confuses the students. Simple understanding of the image. If the umbilicus, this C or this C is seen like this, can you see the C is seen here, and there is a hernia coming out like this. If one C is seen, this one C or this C is seen, and there is a hernia coming out like this, it is known as paraumbilical hernia. Paraumbilical hernia. Paraumbilical hernia. You should watch for the C. This is the C of the umbilicus. If in an umbilical hernia, that C will not be seen like this. You can see the totally there is a this circumference is seen and the hernia is coming out like this. So you will see a O. You will see a O in umbilical hernia. Whereas in a paraumbilical hernia, you will see a C. So in a paraumbilical hernia, C is seen. In umbilical hernia, O is seen. Remember like that. So umbilical hernia, it will come out like this. It's a O. Is an umbilical hernia. If there is a hernia in this place like this, what is that hernia? Can you tell me? I'm just asking you the images that can come for exam. If there is a hernia, this is umbilicus normal. If there is a hernia here, it is known as epigastric hernia of linea alba. Epigastric hernia of linea alba. And please remember, if at all you see a hernia coming from some scar, any scar hernia coming is incisional hernia only, wherever it is. Wherever it is, any scar showing hernia is incisional hernia. Hernia infraumbilically like this, like a bulging, is known as Spigelian hernia. On the rectus sheath, there is a hernia below the arcuate line. At arcuate line, the hernia is seen, that is known as Spigelian hernia. So this is a case of paraumbilical hernia. Please don't forget the hernia. So this question came in NEET PG 2022, guys. Please remember that I'm telling you, FMG questions many times can come in NEET PG also. So this is a white patch leukoplakia. Came in NEET PG this 2022. This question was asked. White patch in the hard palate. So that is leukoplakia. Which of the following is the most common site of malignancy in head and neck? Most common site of malignancy in head and neck is oral cavity. Simple questions. These are all simple questions. Oral cavity. On pathological examination of the breast cancer histopathological examination, signet ring cells are present. Signet ring cells are characteristic of the diffuse gastric cancer seen in E. cadherin mutation. In E. cadherin mutation patients, they will develop diffuse gastric cancer and they will have signet ring cells. These cases may cause lobular cancer of breast. Can cause lobular cancer of breast. Therefore, the answer is A here. But there is one interesting point. There is one interesting point in lobular cancer of breast. When I take biopsy, the cells are arranged like this. What is this? In a lobular cancer, the cells are arranged like this. It is known as Indian file pattern, like an Indians, red Indians walking in a line. The cells will be arranged like an Indian file pattern of arrangement of cells. So Indian file pattern is seen. Please don't forget this question. So it is Indian file pattern. Yes, wherever you get a metastatic from diffuse gastric cancer, you will see signet ring cell pattern. So signet ring cell is like this. The nucleus will be pushed to one side. See, this is a question asking on staging again. So please remember, T1 less than 2, T2 2 to 5, T3 more than 5, T4 is divided into A, B, C, D. A is chest wall involvement. B is skin involvement. C is both chest wall and skin. D is inflammatory breast cancer. So this is a question asking on 6 to 4 centimeter. 6 to 4 centimeter, 6 to cross 4 centimeter means it is T3 tumor. There is a single node palpable here and there is a tumor here. There is no evidence of mets. What should be the ideal treatment? So this is a case of T3N1. T3N1, we have to go for neoadjuvant chemotherapy followed by surgery. Or we can go for MRM followed by adjuvant chemotherapy. So how to decide? This is definitely a tough question for FMG question. For exam in FMG question, this is really tough because stage 1 and stage 2A, 2B, we do directly MRM. We do MRM directly. But for stage 3, we should go for neoadjuvant chemotherapy followed by surgery. So this question is actually a case of stage 3. When you calculate it, it comes under stage 3. Therefore, we have to go for a neoadjuvant chemotherapy followed by surgery in this question. So definitely this question is a little tough to answer. But please remember, it is a locally advanced breast cancer. From the size of the lesion and node present, all those things goes to a conclusion. It is a locally advanced cancer. So locally advanced cancer, we should better go for neoadjuvant chemotherapy followed by surgery. So remember this point. Okay. So postpartum lactating female presents with redness and swelling in the breast. Identify the pathology in the given image. So there is a redness and swelling in the breast. So this is a classical question of a lactating woman. It is mastitis. The mastitis, if it produces fluctuation, that is known as breast abscess. So breast abscess is a favorite question for your exam. So definitely breast cancer question always comes in exam. So you should be thorough with the breast cancer concept, no doubt. And also breast abscess. So this is a case of breast abscess caused by staph, again staphylococcus. So the treatment, latest treatment for this case is, please remember, IND is not the treatment. Latest treatment is ultrasound guided aspiration of the abscess is the latest treatment. Because olden days we used to open this abscess and we have to drain it by IND. Now IND is not done. Ultrasound guided aspiration is the treatment for breast abscess now. So this question again came in NEET PG 2022 this year. The patient was having a, what finding? Your patient is having a pudgy orange. Pudgy orange is obstruction of subdermal lymphatics. Please remember, it is obstruction of subdermal lymphatics. Therefore, what is it? T4A is chest wall. T4B is skin. So this is a skin. T4B is the answer for this question. Simple question. Okay. Radioisotope used in thyroid cancer treatment is. So you all very well know there are two radioisotopes we use. Iodine 131 with the 8 days half-life and iodine 123 with the 13 hours half-life. So iodine 123 is used for diagnostic purpose, whereas 31 is used for therapeutic purpose. Okay, so the answer is iodine 131 is a treatment for cancer. Patient comes with thyroiditis as high TSH and thyroid peroxidase value diagnosis. So diagnosis is already over. TPO, thyroid peroxidase is increased. TSH is increased. TSH increase means it's a case of hypothyroidism. Hypothyroidism with the presence of thyroid peroxidase antibody is Hashimoto's. The most common cause of hypothyroidism worldwide is Hashimoto's. Can you tell me what will be the FNAC finding of Hashimoto's? FNAC of Hashimoto's will show what finding? FNAC will show presence of Hürthle cells. Hürthle cells are seen on FNAC of Hashimoto's. So please don't forget, this is a highly expected question. Hashimoto's thyroiditis is the most common cause of hypothyroidism worldwide. It will produce FNAC shows Hürthle cells. Thyroid peroxidase antibodies are positive. It is an autoimmune disease. A patient comes to you with a thyroid swelling, goiter swelling, T3, T4 increased, decreased TSH. What is the diagnosis? TSH is decreased. What is the diagnosis? So please remember, T3, T4 increased, TSH decreased means it's a case of thyrotoxicosis. Thyrotoxicosis is seen in Graves' disease. The better answer here is Graves' disease. So Hashimoto's, there is hypothyroidism. Physiologically, High thyrotoxicosis is very less common. Plumbers may have, plumbers is secondary toxicosis. That is also can be the answer, but the question is not clear which one they are asking. So better to go for Graves. Plumber is secondary toxicosis. A patient who is having a long-standing thyroid swelling now coming with toxicosis. Here the patient comes to you with a goiter swelling as along with T3 T4 increase. So this question is probably a Graves only. Okay. So 20th question again you see, when I am coming to FMGE June 2021 exam, all the questions are repeat. Male, pale orphan antinucleate, papillary cancer. 30 years old male, female, presented with a mass in the inguinal region which produced a gurgling sound on reduction. The mass completely disappears on pressing. So where is the catch point? On pressing it through the deep inguinal ring. What is the diagnosis? Now the question is asking very simple anatomy question. Which hernia comes through deep ring? So the question is very simple. They are asking which hernia is coming through the deep ring. So this is superficial ring. This is deep ring. This is rectus abdominis, and this area is known as Hasselbalch triangle, and this is saphenous opening, which femoral ring, and this is saphenous opening. So a femoral hernia will come out of saphenous opening. Indirect hernia will come out of deep ring. Direct hernia comes through Hasselbalch triangle. So the question is telling it is going through the deep ring, it is indirect. Simple question. Okay. First MBBS question. A lactating woman comes to hospital with 3 days history of painful red fluctuant. You see now the fluctuant has come. If it is fluctuant, it is abscess. 2 cm mass. Ultrasound shows fluid collection. How will you do the management? So the correct answer here is what will we do for the management of this small abscess? See, it is only 2 cm. So what we can do is antibiotics and follow up for 3 days. Very small abscess may get resolved with that antibiotics and follow up. If it is not resolving, then I go for ultrasound guided aspiration. So otherwise, we will be doing emptying of the breast, no doubt they will be emptying. Heart fomentation may be done. Incision drainage also can be done. So the best next step will be antibiotics and follow up, followed by ultrasound guided aspiration will be the correct answer. So the treatment of choice for bigger abscess is now ultrasound guided aspiration. IND, the concept is gone. Please remember, for breast abscess, IND concept is removed. 32-year-old lady, 2 cm single mobile asymptomatic breast lump. Simple question. Young female, 2 cm mobile lump. Well-defined margin. Patient herself noted this swelling. Presented to OP. She was diagnosed to have a benign lesion on FNAC. You are a doctor, and what will you recommend? If there is a lesion, freely mobile, going here and there. What is a common problem? That is a fibroadenoma. Well-defined border. Fibroadenoma is known as breast mouse. It will move here and there. It is having a Indian rubbery consistency. Treatment is only for cosmetic reasons. We exercise it. Otherwise, reassure and continue the patient to follow up. But most girls will not accept it. They will come for surgery. But surgery is done not for a risk of malignancy. It is done only for the patient's cosmetic purpose. Otherwise, reassure and continue the same as the treatment given by surgeons. A patient presented with a herniation of intestinal loop which passes along the spermatic cord, reaches the scrotum and cremasteric muscle. See, the herniation comes through the deep ring along with the spermatic cord. That is the question. From the deep ring, it is coming along with the spermatic cord, goes into till the scrotum, up to the scrotum. So it is indirect hernia. Same question in a different way. That's all. Same question in a different way. Okay, that's the point you should not forget here. Best prognosis is which of the following breast cancer? Same question again. The best prognosis is with luminal A. Worst prognosis with basal type. So that completes the, see, you are reading so much of time on thyroid, breast, etc. But see the questions. Questions are very simple. Even I used to take thyroid for 4 hours, breast for 3 hours, and hernia for 3 hours, including the laparoscopic anatomy. Everything I used to take in the class in depth, because I never wanted to miss any important points during the lecture class. But this revision class of the previous questions, you can see how simplified and simple the questions are. So I'm sure you are going now confident with this basics of breast cancer. Thank you, Dr. Natasha. Thank you for making a clarity for the students. Thank you, Natasha. Thank you. Very happy to see you on the board. Hope you will be answering the queries from the students on the chat. Because I'm having still more 120 questions to complete. What is the location of Killian's dehiscence? Killian's dehiscence. So it's a very simple question. It is a Killian's dehiscence is a weakness in the inferior constrictor muscle. Killian's dehiscence is a weakness in the inferior constrictor muscle between the cricopharynx. This is cricopharynx muscle. This is esophagus. Okay, this is esophagus, and this is a midline, and this is the thyropharyngeus muscle. Cricopharynx and thyropharynx are parts of inferior constrictor muscle. Okay, they are parts of inferior constrictor muscle. This is one triangular defect. This is one triangular defect on the left. So herniation through this defect is known as Zenker diverticulum. That is known as Zenker's diverticulum. That is known as Zenker's diverticulum. It is seen most commonly on the left side of the neck, common in old age. So the answer here, what is the location of the Killian's dehiscence, is below the inferior constrictor. It is a defect between cricopharynx and thyropharyngeus muscle. A 7-day-old infant presents with bilious vomiting and gross abdominal distension with absent bowel sounds. Please remember, with absent bowel sounds. With absent bowel sounds. So now X-ray abdomen shows multiple gas-filled loops. Diagnosis is. So this is an infant baby. Okay, multiple gas-filled loops. That means the baby is having some obstruction. Gross abdominal distension, absent bowel sounds. X-ray shows multiple gas-filled thing. So now here you should know the points about the vomiting in a newborn baby. So I wanted to clarify this concept. Vomiting in a newborn baby. Non-bilious, it can be two types. Non-bilious vomiting. Vomiting in newborn. Non-bilious and bilious. Non-bilious is only one, that is congenital hypertrophic pyloric stenosis. We are going to see that question. Congenital hypertrophic pyloric stenosis. Bilious is of many types. Duodenal atresia, jejunal atresia, midgut volvulus, very dangerous problem. Midgut volvulus. So duodenal atresia, jejunal atresia, midgut volvulus, these all can be diagnosed with a simple X-ray. Congenital hypertrophic pyloric stenosis will show this. Duodenal atresia will show this. Jejunal atresia will show this. Midgut volvulus will show this. So now tell me the answer. Single bubble in congenital hypertrophic, double bubble in duodenal atresia, jejunal atresia will have triple bubble, midgut volvulus or distal problems will have multiple air fluid levels. So the best answer for this question is a malrotation of gut will be the better answer, because patient is having multiple gas filled loops. That patient is now going for paralytic ileus. That is why the patient is having absent bowel sounds. Paralytic ileus, that is why the patient is having absent bowel sounds. So please remember, answer is malrotation of gut. Okay. Very good. Very good, Shakir Khan. That's correct. Triple bubble is meconium ileus is a presentation seen in which of the following? Please remember, presentation seen in which of the following disease? So meconium ileus is a condition in which thick meconium gets obstructed in the terminal ileum like this, like a tar, like a road tar, they will get obstructed and they cannot pass a motion. It is seen in cystic fibrosis. The important cause for this is cystic fibrosis, also known as mucoviscidosis. These are all repeat questions can be expected this year. Please be thorough. Mucoviscidosis or cystic fibrosis will cause meconium ileus. Meconium causing obstruction of the ileum. Okay. Which is the first investigation to be done in a case of neonate presenting with the frothiness in the mouth and dyspnea. So now again, so there will be definitely a question in your exam, a problem based on neonatal issues. Okay. Now, neonate, the questions which can come for you are, number 1 will be on tracheoesophageal fistula, will be one definite question for your exam. That question. Number 2, congenital diaphragmatic hernia. Number 2. Number 3, about the atresias which I told you just now. A newborn baby can present to you with the tracheoesophageal fistula, means what they will have, what symptom they will have. There is an atresia of the esophagus, so they will have drooling of saliva. The clinical question will be a newborn baby with a drooling of saliva, inability to pass Ryle's tube, The question will be telling drooling of saliva with inability to pass Rayleigh tube. What is your diagnosis? It is congenital tracheoesophageal fistula. A newborn baby with having breathlessness. So in a tracheoesophageal fistula, when you pass the Rayleigh tube through the nose, it will come out through the mouth. That is known as coiling of Rayleigh tube. Congenital diaphragmatic hernia, baby is having breathlessness, and when I am putting a bag and mask ventilation, the baby is getting more breathless. So therefore, bag and mask ventilation is contraindicated, and when I put a Rayleigh tube enters the chest because stomach is in the chest. So it is going into the chest. So atresia, just now I told you, bilious vomiting will be present. So the question here now is, what is the first investigation to be done in a case of neonate presenting with frothiness in the mouth and dyspnea? So this can be a case of tracheoesophageal fistula. So now what can I do is, I can go for a nasogastric tube insertion and chest x-ray to locate the position of the tube. That will give you a clue now. They are asking what is done next. So what is the first investigation to be done is taking a nasogastric tube and putting a chest x-ray. So everything in this will be done. Endoscopy will be done, bronchoscopy will be done. The first thing next to be done is nasogastric tube insertion. So this is again a very favorite national board exam question. The best treatment for anal squamous cell cancer. Squamous cell cancer of anal canal. What is the best treatment of anal canal squamous cell cancer is chemoradiation. Can somebody tell me what is the name of that regimen? Chemoradiation, the name of the regimen, chemoradiation. Yes? Negro regimen. Please remember, it is known as Negro regimen. Negro regimen is a chemotherapy plus radiotherapy given regimen for squamous cell cancer of anal canal. This question can again come for you. Please remember. So, and one important thing in GIT I want you to remember is Crohn's and ulcerative colitis. You should know everything about Crohn's and ulcerative colitis. In our material, I have given a table of Crohn's and ulcerative colitis, full length table. You read that table in this revision days. So please don't forget Crohn's disease, which is false. Simply you can answer the question without even reading anything for the exam. But just I want you to have a clear-cut idea about Crohn's and ulcerative colitis. Crohn's is an incurable disease. Please remember, it is an incurable. It will recur. So the answer is no occurrence after surgery is wrong. It is a recurrence is common. Aphthous ulcer is seen, skip lesion seen, fistula are seen in Crohn's. So which area is not affected in Crohn's? Rectum is spared. So rectum is spared in Crohn's. So please remember, rectum is spared in Crohn's disease. So very simple, when you see gastrointestinal tract, so whatever we discussed in section A and section B are basic MBBS questions. So now what we are going to see in section C, D, E are all high level questions. They are all like PG level questions. So they won't be going in depth in these questions. They will be asking only superficially. So you can answer most of the questions simply by understanding the questions. Okay, which of the following is not done in cancer? You just think, why should I do a pH monitoring for a cancer? I will take biopsy, I will take CT chest, I will take PET. pH measurement is done only for GRD, gastroesophageal reflux disease. I will do 24 hours ambulatory pH monitoring, and I will do a score known as D-Meester score in that case. So only for a GRD I will do a 24 hours pH monitoring and a D-Meester score. It is not needed for cancer. Cancer we need endoscopy and biopsy. 30-year-old man presents with 4 days history of right iliac fossa pain. Ultrasound image is shown below. What is the best management? So some of you asked about ultrasound appendicitis before. Please remember, appendicitis and cholecystitis, you should not have a confusion. Diagnosing of appendicitis and diagnosing of cholecystitis. I don't know why you should get a confusion in this, because appendicitis will have a triad known as Murphy's triad. Murphy's triad says there is a pain in the right iliac fossa, pain. Murphy's sign is seen. What is Murphy's sign? Right hypochondrial pain on a deep breath. When you take a deep breath, there is a pain on the right side hypochondrium. There will be a pain on the right side hypochondrium. There will be severe pain on taking a deep breath in Murphy's sign. Number 1. Number 2, they will have postprandial pain. After they eat, they will get more pain. That is another feature of cholecystitis. So appendicitis or cholecystitis, the investigation of choice is ultrasound. So not investigation of choice. The next done investigation in appendicitis as well as cholecystitis is ultrasound. Investigation of choice in appendicitis is CECT abdomen. Gold standard in cholecystitis is HIDA-scan. Cholecystitis, the gold standard is HIDA-scan. So please don't forget, these are very important points for your exams. You should not forget. Shilpa Anand, I will tell you, don't worry. At the end of the session, you tell me, remind me, I will tell you the direct and indirect hernias. So please follow the question because I have 120 questions to be discussed. Only when you allow me to complete the discussion, I can complete it. Otherwise, after some time, my laptop is already getting hot in this OBS software. It will start dancing after some time. So let me try to finish off the questions of GAT at least first, then I will clear your doubts. So appendicitis, this is a case of appendicitis. Not only appendicitis, the patient is also having a mass. Can you see? There is an inflamed appendix with a mass. Appendicular mass is a complication of appendicitis which is improperly treated or semi-partially treated cases. So appendicular mass, we cannot do appendicectomy. So what is the treatment for this 8th question? My question is 8th question. What is the treatment? The answer is Aschner-Sharon regimen. Answer is Aschner-Sharon regimen is answer for this question. Okay. The patient should be treated. Appendicular mass is treated by Aschner-Sharon regimen. Appendicular mass is treated by Aschner-Sharon regimen. Okay. So comment on the diagnosis of the film shown here. Again, this is a very favorite question for National Board examiners. This question came in NEET PG 2022 also. So NEET PG 2022, around of the 22 questions came out of 200 questions are surgery questions. Of that, 12 questions are FMG questions. Are already asked FMG questions are asked in the exam. Comment on the diagnosis of the film in a patient with an old man with an acute abdomen having a class sign. This is a class sign. So class sign in an old man is usually a case of colocolonic interception. Ileocolic is common in children. So old age, it is colocolic interception usually due to a cancer. Please remember, in old age it is usually a colocolic interception due to cancer. But in children it is usually a ileocolic interception due to hypertrophic Peyer's patches. It is usually due to a hypertrophic Peyer's patches. Okay, please don't get confused in this. So ileocolic is hypertrophic Peyer's patches. Colocolic is seen in old men. The question is very clear. 65-year-old man. No need to even read the choice. You can go with a 66 old man will have colocolic. Otherwise, young age, small babies, everyone will have ileocolic. Okay. So question on ulcerative colitis. Emergency surgery is indicated in ulcerative colitis in all except. So ulcerative colitis, emergency surgery is indicated for toxic megacolon, no doubt, perforation, obstruction, not for fistula. So emergently, when will you operate ulcerative colitis? Means answer is toxic megacolon, colonic perforation, colonic obstruction. Okay. In these cases, I will operate the cases as emergency. It's done as emergency. The gold standard treatment for an elective case. Electively, if I am operating for ulcerative colitis, what is the gold standard treatment? I will do TPC plus IPAA. What is the answer? Total proctocolectomy with ileal pouch like this. Ileum is made like a J pouch like this and anastomosed with anus. Ileal pouch, anal anastomosis is the treatment for these patients of ulcerative colitis. Total proctocolectomy with ileal pouch, anal anastomosis is the treatment electively done for ulcerative colitis patients. Please remember that. 20 years old female diagnosed as adenocarcinoma stomach, and on examination the following is seen. See, we have seen around 55 questions from general part, 25 questions from thyroid breast. There are 56 to 60 questions in GIT. GIT is one of the favorite areas for FMG examiners. Definitely you are going to get 12 to 15 questions only from GIT part. Adenocancer of the cancer stomach, and the baby is having a umbilical deposit, and the female is having a umbilical deposit. It is known as Sister Mary Joseph nodule. It is a metastatic deposit. Metastasis from cancer stomach. So please remember the other important things from cancer stomach, that is Krukenberg's tumor is a bilateral ovarian deposit. Krukenberg is a bilateral ovarian deposit. Irish node is an axillary node, left axillary node. Virchow's node is a left supraclavicular node. Bloomer's shelf is a pouch of Dowler's deposit. So all these are metastatic findings. Krukenberg's tumor, Irish node, Virchow's node, Bloomer's shelf, Sister Mary Joseph. All these are cancer stomach metastatic deposits. So distal ileum was removed in a 20-year-old girl. What absorption is deficient? Actually, this is a physiology question. I can tell you, no, most of the questions are physiology questions and anatomy questions are now asked as applied questions. So the terminal ileum, what are all observed here? Terminal ileum, we have absorption of B12 and bile salts. Bile salts is enterohepatic circulation of bile salts happen. B12 is also observed here. So which absorption deficient will be therefore here? Bile salt deficiency and B12 deficiency will be seen in distal ileal resection. Okay, not folic acid, not folic acid. It is B12 and bile salts, not folic acid. So bile salt is not absorbed, so the patients may have steatorrhea. Bile salts are very important for fat digestion, so they may have a steatorrhea. 28-year-old alcoholic patient walks to hospital with the complaints of binge vomiting, chest pain, fever, pneumomediastinum. What's the diagnosis? So this is my favorite topic on binge drinking and vomiting. This is a case of Borav's syndrome. I used to take this in regular classes. I hope you remember. One day Ramu and Mr. Somu are going to take a binge of alcohol. They are taking multiple rounds are going inside. Both of them vomited. Ramu collapsed. BP Kuri, pulse Kuri is collapsed. Taken in 108 ambulance to GH. Whereas this fellow Somu himself walked to hospital after vomiting with the hematemesis. He was having only hematemesis. He went to hospital with hematemesis. So what are the two differences? This guy had Borav's syndrome and this guy had Mallory-Weiss. So Mallory-Weiss and Borav's syndrome are the two cases you are seeing here. Please remember, Borav's syndrome is due to rupture of the esophagus. That's due to the rupture of esophagus. Mallory-Weiss tear is a tear in the OG junction. Partial tear, it is not a full tear. So Mallory-Weiss tear therefore will bleed, but nothing will happen. The bleeding will stop by itself. Whereas Borav's syndrome is a rupture of the esophagus in the lower left posterior esophagus. So they come to you with the triad of Mackler's. Mackler's triad is vomiting, chest pain, subcutaneous emphysema seen in Borav's syndrome, also known as barotrauma. Vomiting, chest pain, subcutaneous emphysema, known as Borav's syndrome. See the simple question. So we are discussing FMGE 2019, all the surgical gastro part of the questions. True about Crohn's disease is except. Recurrence is common, true. Rectum is involved is wrong. Just now I told you rectum is paired. Fissures are formed. It is transmural. Please remember, Crohn's is a transmural disease. Therefore, they develop strictures. Patient underwent gastrectomy and after eating within 20 minutes, sweating, diarrhea. What could be the cause? So please remember, this is a case of gastrectomy is done and the patient is having a GJ like this. So what happens therefore after eating, the food is dumping inside the jejunum. So within 20 minutes what you get is known as early dumping. If you get in 2 hours, it is late dumping. So 30 minutes if you get something, the problem is early dumping. It is due to massive fluid shift. If it is happening after 2 hours, it is usually due to hypoglycemia. Remember this part. Mallory-Weiss tear, Herman revealed the treatment of choices. Why this video is stuck? So Mallory-Weiss tear, there is nothing to worry that it will. So the video got stuck up. I don't know why. Actually, it's raining in my place. Is the video stuck for all of you? I'm seeing some stucking up on my other device. having a. So to see whether it is coming. Let me see. I think we have rectified it. I think it will come now. See whether it is coming. Yeah, I think it is now okay. Power is going and coming on in between. That's the reason. But it's fine now for me. So I don't know, this is device also becomes very hard in OBS software after some time. That's the problem. Am I audible now? I will explain. Just I'll verify whether it is working first. I am unable to continuously. No, it is lagging. I think because of the rain, I think I will not be able to continue. I am seeing in another device. No, it is showing there is a huge lag. No, it is not. I think friends, I will start with from the Borah syndrome topic. I will from the 13th question I will continue, because there are 100 more questions. I need at least 1.5 hours time to complete. So we will have it another day. There is a huge rain and thunder here. That is the reason. So probably by Friday I will try to finish off the remaining topic. Now the video is completely. I am seeing in another device here. No, in another device I am seeing here. So I could see there is a huge lag. I'll complete it, don't worry. I have around 100 questions to complete. So this is not coming. I'm seeing the video. It is totally stuck up, not moving out. So probably because of the rain, not due to anything else. There is a huge rain here. So I have some questions to complete, but I will complete the remaining questions before this weekend. Okay, either I will do it on Friday or on Sunday. On any of these 2 days I will be covering the remaining topics, and I will give a separate time for all your doubts. So all your doubts also will be cleared on that day, so don't worry. I will make your surgery easier. At least 25 questions I guarantee you will answer based on my discussion. So I will complete the remaining on Friday or Sunday. Okay.